I welcome you all on the first webinar on adipose cellular fraction, or you can call it SVF. It is stromal vascular fraction, which is derived from autologous adipose tissue. So, in this webinar, we will discuss how this process is done, what are the advantages of this procedure, how the cells are separated, and what is our experience of doing adipose-derived stromal vascular fraction in osteoarthritis, and little experience on AVN also. I would like to start our first presentation. Good afternoon, friends. Today we are going to start with our first talk, adipose-derived cellular fraction or SVF in osteoarthritis and AVN. So first of all, we need to understand what is SVF. So SVF is a heterogeneous mixture of cells. It consists of the extracellular matrix, pericytes, mesenchymal cells, endothelial progenitor cells, B cells, T cells, mast cells, and M2 macrophages. And out of this, the most important cells are these, the mesenchymal stem cells. And these have potentials to differentiate into the multiple tissue types like the muscles, bone, fat, and the cartilage. So these cells, the mesenchymal stem cells, what are these? First, we need to understand what are MSCs. MSC's name was given by Arnold Kaplan in 1991 for the cells or the group of cells which can regenerate tissue in the embryo or the childhood, or can repair and help in healing in the adults. So these cells were called stem cells, but Arnold Kaplan himself told that the time is now came to change the name of MSCs. Why? Because these are not the true stem cells. True stem cells lives in the embryo and before the birth of a child. So after that, these are the adult stem cells or the MSCs, which are important for the repair and regeneration or the healing of the tissue. So he called them MSC, the medicinal signaling cells. These cells are the injury specific drug house. So these cells are responsible for the healing of the tissue, regeneration of the tissue, and these are the helpers for the repair. These cells give signals so other cells come and repair the tissue. So which were these cells? These were the pericytes. The pericytes which lives or which are occupying the outer shell or the outer surface of the capillaries. These MSCs are now known to originate as pericytes, which function as surveyors of their kingdom, capable of responding to local environment stimuli with a myriad of beneficial interventions. So you can see these red cells which are lying on the wall of capillary. These are the pericytes. So these are the pericytes which are responsible for the healing and repair and regeneration of the tissues in the adults. So we take advantage of these cells for the treatment in early osteoarthritis, for pain relief, for healing and repair of the cartilage, so that the patient can have improved function, relieved of pain, and better quality of life. So these cells, from where we can harvest these cells, from where we can get these cells are present in all over the body, but we can take it easily from two sources. One is the bone marrow concentrate and other is the adipose cellular fraction. So bone marrow concentrate, we can harvest those cells from the iliac crest, anterior iliac crest, or the posterior iliac crest, or from where but the adipose derived cells we can harvest from the adipose tissue of the belly fat. We can harvest it from the buds, we can harvest from the breast, or from the portion where the fat is. So these are the adipose derived stromal vascular fraction, which are we are taking advantage for the treatment of osteoarthritis. Okay, so these cells are present in fat were identified by the Patricia Zook in 2001, and they also found that these cells in the fat are 100 to 1000 times more as compared to bone marrow. And we all know that in the these bone marrow cells decreases with age, but the fat cells do not decrease. Another thing, the number of cells which are present in adipose tissue we harvest it are much more as compared to bone marrow or other source, so we need not to culture them to increase the number. So that's why we rely and we take advantage of the adipose-derived stromal vascular fraction for the treatment of osteoarthritis as well as in the AVN. So the major advantages of the cells, SVF cells, are because these are the mesenchymal in origin, they are more in the numbers, we do not require to culture it, we do not do any kind of manipulation, it is just harvested by the minimal manipulations. Time harvesting is lesser than the cells which we take in the bone marrow, and it does not decrease with the age, and it is a less painful and less invasive procedure in comparison to the bone marrow. But from the fat, there are different ways to harvest the SVF, and in the past it has been done with the help of the collagenase enzyme. So collagenase enzyme basically emulsifies the fat, and the fat part is digested and the vascular fraction is separated. But what we do, we get it from the ultrasonic cavitation. Ultrasonic cavitation is important because it does not involve any enzyme, it does not require any chemical, and it is faster, as well as it is able to preserve the bioscaffold or the extracellular matrix. Okay. So there are three simple steps in administration or doing the SVF in the osteoarthritis or the bone marrow. First is the lipoaspiration. Lipoaspiration is usually done under the local anesthesia. We'll discuss, I'll show the video of the procedure later on. We give the local anesthesia on the belly fat along with the local anesthetic drug, normal saline, adrenaline, and then we harvest it or aspirate it with a 3 millimeter cannula. So the incision is such a small incision that we need not to close it or we need not to suture it, and approximately 30 minutes time is required to harvest 300 to 400 ml of the adipose tissue, which is generally required in our process. Okay. And second step is the processing of the tissue. Processing means from the adipose tissue which we harvested approximately 300 to 400 ml of the fat, from that fat how we get the SVF. So this process approximately takes 40-45 minutes, from which we do separation of the local anesthetic drug, then we do the ultrasonic cavitation, 1 or 2-3 cycles of the centrifugation, cell filtration, and then cell administration, which is usually in osteoarthritis we do under local under ultrasound guidance, or we orthopedic surgeon are well trained and accustomed to give intra-articular injection without any guidance also. So that is given in the knee joint in suprapatellar pouch. That's a very easy and procedure which we can all do it. So we inject it under the without any anesthesia in the suprapatellar pouch. The SVF injection is administered into the knee joint without any difficulty by the orthopedic. So that is not an issue. But in case of AVN, we use the help of C-arm so that we can target the exact lesion, which is usually the anterior superior lesion in early case of AVN, because we give it in early AVN only. We do not do SVF for the grade 3, grade 4 of AVN. We do only for the grade 1 and 2 of the AVN, which is very important, and I think it is very useful procedure in younger patients, 20 to 30, 35-year-old patients who are getting their hip joint destroyed by the AVN process. So it is very minimally invasive procedure which we give it into the patients. So these are three procedures. And one more thing which I forgot, before administration we always do the cell count and the viability check of the SVF. So we know that how much amount of cells we are injecting into the into the joint, and these cells are actually viable or not. So that is done with the help of cell counter flow cytometry, which we will again discuss into the workshop live surgery part. Okay. So what's my experience? I have done 201 joint of SVF in osteoarthritis in last 5 years, and mostly the grade 3, but grade 1 and grade 2 I have done it in also, and I have done grade 4 also, but nowadays I am not doing it in grade 4. So currently my indication is grade 1, grade 2 osteoarthritis and early grade 3. Okay. So the results in these last 5 years are very encouraging. All the parameters of the KOO scores like the pain, symptoms, activity of daily living and quality of life, these all parameters have significantly improved over a period, and still in 5 years approximately 80 to 85% patients are doing well. And the amount, the significance means the patients who are comfortable and happy with the procedure, approximately 75% improvement in the KOO score. Okay. In the avian, what we have done is 6 years, 59 joints, 31 right hip and 28 left hip, and we have found it gradually improve in the function and improve in the WHO score in the patients. So these two indications I'll suggest to go with the SVF, and results are very good. Not 100% patients are improved, approximately 10 to 15% patients of the avian are also deteriorated and their disease progress, but it is giving fantastic results in avian. And since last 2 years I started using the SVF in the hip joint as an intraosseous injection. Harnigu et al. Has a very nice paper, and they have 30-year follow-up of administration of MSCs into the bone as an intraosseous injection, and they have also shown that the results are very good with the MSCs, although most of their studies were including the bone marrow derived MSCs, but they have given it an injection as a intraosseous injection, not injection given after co-decompression. Okay. So thank you guys. After this we will break for a small session of question and answer, and we'll come again to our next talks. Yeah. So if there is any query or the question answers regarding to this talk, we can take those questions right now, and then we'll move to the next talk. Hello. Okay. So we can take a next talk if there is no question in this talk. We have got approximately 93 participants who have joined this meeting. So we can take question answer also later on related to this talk also, but for the sake of time and all the meeting to progress in time, we can move to our next talk, which is on the mechanism of action of MSCs. So we by this time we have known that these MSCs, which are derived from the adipose derived stromal vascular fraction, are the key factors or the key cells which work for the regeneration and the repair of the tissues. So the MSC name per se, the mesenchymal stem cell, was initially MSC name was given by the Arnold Kaplan, and these cells are basically the pericytes which when activated start the process of repair and regeneration of the tissues. In osteoarthritis of the knee joint, we have seen it, good results, and in avian also. Initially, we were injecting the in avian cases also the intra-articular injection, but now we give it intraosseous only. So intraosseous injection gives very good result for the healing and repair in the tissue, and the progression of avian is halted, and patient also get benefit out of it. So currently for the two indications we are doing this adipose derived stromal vascular fraction, and now we'll go to another talk where we'll know how these MSC work basically. Okay, so the basic mechanism how these cells work in the next talk. Thank you, friends. After completion of our first talk and nice question and answer session, we'll come to our next talk on mechanism of action of adipose derived SVF. So how SVF work? It is very important to understand how SVF work and what is responsible for the positive outcome or the results of the SVF. Okay, so we all know that the SVF is a heterogeneous combination of different cells such as the pre-adipocytes, pericytes, endothelial progenitor cells, T cells, B cells, mast cells, M2 macrophages, and extracellular matrix. So these all components play important role in the treatment part. We all know the slide we have seen in the last presentation also. It consists of various cells, and most important of them is these MSCs, but endothelial progenitor cells which have angiogenesis and anti-inflammatory action, B cells, T cells which have immunomodulation action, and macrophages which has an anti-inflammatory action again play a major role in the outcome of the patient. So we all know the mesenchymal cells have a potential to differentiate into the many tissue types like the muscles, bone, fat, and the cartilage. The effect which we get from the MSCs or the adipose derived SVF is because of the 4 or 5 reasons. One of them is the homing effect. What is homing effect? Homing effect is an effect in which the cells, when they are injured or have some problem inflammatory area, the cells send the signals, and the cells which helps in repair and regeneration come and act to that part. So in this effect, the cell migrates to the site of injury, and these cells migrate to the targeted tissue through a different signal, and repair of the damaged tissue is done. Okay. Second is the anti-inflammatory effect. Anti-inflammatory effect of the SVF is seen because of the immune modulation effect of the cells and their secretions of the cytoprotective agents and inflammatory agents. Okay, secretions of various cytokines, it is very important, and it prevents the apoptosis of the cells. Apoptosis means the cell death. So it prevents the degradation and help in the regeneration. And not the least, extracellular matrix role. Extracellular matrix plays an important role in the formation of the scaffold, and we all know the importance of scaffold in tissue engineering. In tissue engineering, there are 3 factors which are important. One is the scaffolds, another is the cells, and third is the bioactive molecules or the secretions of these cells. So the extracellular matrix, which is preserved in SVF, plays an important role, because we all know the cartilage, about 70% of the cartilage is a scaffold or extracellular matrix or the collagen fibers. So this scaffold is also very important in repair and regeneration of the cartilage, and it also promotes the angiogenesis. The cells, when there is an hypoxia or there is a decrease in oxygen concentration of the tissue, it is destabilization when it is done in the process of hypoxia. The cells, these you can see, these blue cells are the pericytes. They help in the formation of newer vessels, and this is the process of neoangiogenesis, and because of this neoangiogenesis we get advantage in avian cases and tissue repair cases. Okay, thank you very much. Now we will take questions for this session, and then again we'll come to the our next talk. Thank you. Yeah. So thank you. There is a question by Ravinash Patel. What do you mean by intraosseous injection? Whether it is injected after core decompression? So the meaning by intraosseous injection is putting an injection into the bone directly. So intraosseous injection has been described in literature. It is given by little thicker needle into the joint or into the bone directly, and it is just like any other injection. It takes little more pressure to inject the SVF into the bone, but it spreads well. We have few images. If I'll able to share you, I'll show you in the later on. And we have a video technique also. How do we inject SVF into the bone directly as an intraosseous injection, and it is not injected after core decompression. In our case, we don't inject it because initially I was doing the core decompression also along with SVF and BMAC also, but what I have seen that there is more collapse in the bone if there is subchondral bone and that area is cleared and it is devoid of any support. So collapse is because of procedure itself, it can collapse. So we inject it, and the main aim of core decompression, as per my understanding, is to relieve the pressure which is increased, the intraosseous pressure which is increased into the head of the femur, which is the cause of pain in grade 1, grade 2 avian. For relieving that pressure, we used to decompress the core, and that's why it has been suggested that multiple drilling is also working, because principle of multiple drilling was also the relieving of the pressure or the decreasing, just making a holes. So this needle can also decrease the pressure from the bone, and that's why we see the improvement in the pain after injection into the hip immediately after the procedure from the very next day onwards. Okay, so any other questions related to the mechanism of actions in this session?
Dr. Vinay,
Yeah.
am I audible?
Yes, yes.
Dr. Vinay, what is your experience regarding any cell count or viability? Do you note all this?
Yes, I'll show you. After every procedure of SVF, when we extract the SVF or when we separate the cells from the adipose tissue, we always do the cell count and viability check, so that we are giving the right thing or not. So this is done by a machine which we have a Muse. It's by the Merck, and based on the principle of flow cytometry. Flow cytometry is the basic principle by which these lab guys or the pathologists do the cell count and all those things. That is the basic principle, and by that we always do the cell count and viability check, and it is encouraging that we get more than 85% viable cells, and approximately 1 million cell per gram of fat we get it. So approximately 300 to 400 ml of fat which we take it out, we get 300 to 400 million cells also. And literature has proven that more number of cells are, if they are given, the results are better and results are good in those cases. I think I'm clear by that. There is a question, how much injection needed in osteoarthritis and at what interval? So Only single dose injection of SVF is given in osteoarthritis along with 2 doses of PRP to facilitate and activate the effect of SVF. The results, one is given after 24 hours and another is given 3 weeks after first SVF. And question, how and where the injection of SVF in avian is given, we will show it in the video. It is directly into the head of the femur, targeting the affected part under C-arm guidance. And third question, how to make SVF from fat cells. So basically this SVF is not a product of fat cells. We discard all these fat cells. We collect only the stromal vascular fraction, the microvascular circulation or the microvascular tissue in the adipose tissue, in the fat. Fat is well supplied with the vascularity. It has lot number of many capillaries, and on these capillaries and the pericytes which lies on the wall of these capillaries are separated, and it is separated by the process of ultrasonic cavitation. So whole process will show you in the form of video after next talk. So any more questions? Otherwise we will move to our next talk. So if you have any questions in between also, you can put it on the chat box. We will take one by one all those questions. And now we will switch on to our next talk, evidences of SVF in osteoarthritis. Thank you friends. Now we will start with another talk, the evidence of adipose derived cellular fraction in osteoarthritis. So the evidences are collected in 3 groups: the pain score evidences, the MRI evidences, and the arthroscopy evidences. So first of all, we'll take a study by the Zaraslow Michaelek in 2015. They have done autologous adipose derived SVF in osteoarthritis in 1128 patients and 1856 joints. And this is the study which has the largest number of the patients, and they use the modified Coos clinical score to assess the outcome. There was no serious side effect, systematic infection or cancer in the patients. The most patients gradually improved over 3 months to 1 year time, and at least 75% score was improved in 63% patients after 12 months, and 50% score improvement in 91% of the patients in 12 months. Obesity and high grade of osteoarthritis were associated with slower healing. Okay. And another study by the Michaelek, which published in 2019, SVF cell therapy for osteoarthritis in elderly, multicentric case control trial. They included 29 patients which were older than 80 years, and all those patients have no complication associated with the processing of the SVF. Local pain and the minor symptoms which were there for 1 to 2 days were present in only 2 cases, and there was no long-term side effect or the complication. So it is also safer in the elderly population. Another study, which is a double-blind randomized control trial on clinical efficacy of intra-articular MSCs or the mesenchymal stromal cells for the treatment of osteoarthritis by the Garza et al. Multiple prospective double-blind randomized placebo-controlled clinical trial was done, and 39 patients were randomized to high dose of SVF, low dose of SVF, and the placebo. And in this study, they have assessed the WOMAC score and MRI images at 6 months and 1 year time. The mean percentage of the WOMAC score at 6 months after injection of SVF in high dose case was the 83.9%, low dose it was the 51.5%, and in the placebo it was 25% at 6 months. But if you see this carefully that at 1 year time, the effect of high dose SVF were persisted in 89.5% cases, which were similar, and further increased. Low dose SVF effect further increased in 68.2% cases, versus there was no improvement in placebo group. So it is definitely more effective and has high rate if you give more number of cells of SVF in osteoarthritis cases. So you will get a better results, and you are damn sure about that it is better than the placebo at all. MRI evidences which we see in intra-articular injection of autologous adipose derived stromal vascular fraction in osteoarthritis, a double-blind randomized self-controlled trial by the Zepping Hong. In this, they have studied 16 patients on the basis of MRI at baseline, 6 months and 12 months, and they also assessed the WOMAC score, VAS scores, and the MRIs and the range of motion, and they have found it the Mocard and the WOMS measurement were significantly improved in the patients. You can also see that there is integration of the chondral flaps in patients over 6 months and then over the 12 months, as well as subchondral cortical lesions are healed, bone marrow edema is healed. Another study of the Michaelak in which they studied the MRI, they have seen that there is a improving the thickness of the cartilage after 6 months, and after 18 months they have seen that there is improvement in the subchondral lesions, which is now healed and it is covered with the thin cartilage layer over the subchondral bone. Another study which was done by the Yin Zhang, the effect of adipose derived stromal vascular fraction on cartilage regeneration. It was quantitatively evaluated based on the 3D FS SPGR sequence. They have assessed it over 6 months and 12 months, and cartilage was characterized into 6 different regions relevant to that, and they have found that the regions which they have identified were denoted by these different colors. And if you see it in the baseline 6 month and 12 month images, you will see there is significant decrease in the chondral lesions. You can clearly see here this lesion is decreased gradually, and over the 12 months it is so small size. Similarly, all the lesions in all places were healed. Arthroscopic evidences, you can see the study where they have seen that the baseline cartilage, the bone which was denuded with the cartilage, is now covered with a hyaline-like cartilage. You can see similarly here in the tibial surface, there was no bone, it is a bare bone, and now it is covered with the hyaline-like cartilage of the bone. Okay. Another study in which they have seen the second look arthroscopic findings after SVF injection. It was done by the Co, and they have also seen that intraoperative findings that these lesions, bare bones, when injected with the SVF over a period, are covered with the hyaline-like cartilage onto the bone, and the defect is completely covered. Another study where they have compared outcome of the open wedge high tibial osteotomy with platelet plasma alone or combination of MSC, prospective study over 7 months postoperatively. The lesion is healed well. This is the HTO with the PRP, and this is with the SVF. So the evidences to me are quite fascinating and quite attracting, and I am convinced with these evidences which are there in the literature, and we can discuss these things later on also. Now I'll come to the patient selection criteria. Who are the patient to which I will offer the SVF, and to the patient in which I will say that the SVF is not a good choice. So the exact or the correct indications are the young arthritic patients who have early osteoarthritis, and the relative patients, which are patients not fit for the major surgery, or the patient who are absolutely not willing for the surgery but still they want pain relief. So these are the relative indications, but the absolute indications are the young arthritic patients and the patients with early osteoarthritis. So what are the factors which are to be considered for the treatment of osteoarthritis with the SVF? So age is definitely one thing we should take it in consideration, because if we have seen that if other methods, surgical methods like total knee replacements are offered in osteoarthritis in younger than 55 years of the age, there is 1/3 of the patients required revision surgery in less than 10 years of time. So age is definitely a criteria. So I will offer SVF to the patients who are relatively younger in age, definitely less than 55 years. I will try to preserve the joints. Sex is not a much difference. You can go for SVF in either sex, no issues. BMI definitely important factors. In our study also we have seen that the higher the BMI, obese the patient, the results are less encouraging. Deformity, definitely if there is a mechanical deformity we should not go for SVF. We should try to correct deformity, and then SVF can be supplemented to get a better results, as we have seen in the article by the Co et al. Recently. Stability is important, because if joint is not stable, any kind of cartilage procedure or the procedure which is done for the knee preservation is not going to last. So all kind of instability should also be dealt first, and then SVF should be considered. Grade of osteoarthritis, because we do it for grade 1, grade 2 and early grade 3. I have done SVF in grade 4 patient also in the past, but I have seen that the results are not good, and the results are not lasting also. That initially the patient also can have a good pain relief, but that doesn't last for more than 2 years. So it is not midterm results are not satisfactory if it is done in later stages. Compliance of the patient is definitely important, because after SVF we advise them to follow a proper dietary habits and do proper exercises, and should not have exertion or sporting activities for at least initial 3 months. So if the patient is not compliant, then you should think of that whether we should offer the procedure to them or not. And the expectation of the patient, most important thing in any procedure, expectation of the things, because if patient expect too much, or if there is unrealistic expectation of the patient, you should always consider for any of the procedure, not only the SVF, any procedure, you have to understand if the expectations are not true or genuine, then we can land up in the problem that they will come to us and will ask that I am not relieved, I am not 100% improved, which I suppose, which I thought I should have done. So we should discuss the thing what we can offer to them, and we should also listen to them what they expect from us. Okay, so this is a major thing. SVF in early grade 1, grade 2 and early grade 3 without deformity. SVF with proximal fibular osteotomy if the patient is older in age and deformity is more. And if patient is younger, I definitely give or advise them high tibial osteotomy to correct the deformity, and then I do the SVF in those patients. This is the gross thing for me what I follow. It's not a compulsion or a protocol which everyone should follow, but this is the broad thing which I offer to my patient. There may be some expectations, so there may be some exceptions in change in the protocol, but this is just a gross thing. So grade 1 yes, grade 2 definitely yes, in grade 3 You have to see whether you should do it or not do it, but no SVF. I don't offer them in grade 4. Okay. And in AVM, definitely I'll offer any kind of joint preservation procedure in stage 1, stage 2, but not in the stage 3 and stage 4, because once the head is collapsed or the shape of head is changed, I think this is going to deteriorate over a period of time, even if it is preserved. Okay. The patients in which I don't offer SVF at present, in the grade 4 osteoarthritis, the patient who have joint laxity, patient with the loose bodies, because this is a mechanical symptom, either you remove it, then you do it. So in presence of loose bodies, I don't do SVF, I remove it and will do it later on. Excessive osteophytes, I know, don't do it. Over expectation of the patient, I give them a reality or give them a realistic statement what they can achieve, and very high or very low BMI. Very low BMI, why? Because in those patients we cannot harvest the fat. So if we cannot harvest the fat, how can we do the SVF? So very high and very low BMI patients. Pregnant and lactating patient, I don't touch them. Patients with having the gout or pseudo gout, altogether different pathology, we don't do it. Patients with active history of cancer or active cancer in last 5 years, we don't do it because we have never tried it, although we have never seen any kind of teratogenic effect of SVF, or even the literature doesn't support any teratogenic effect of the SVF. And the patients younger than 21 years, no experience, active or latent infection, we don't do it. In HIV patient, we don't do it because in HIV patient there is there is immune compromised patient, and how these SVF cells will react and will act in immune compromised patient, absolutely no ideas. Red flags important. You unmeasurable expectations. The patient asks for a guaranteed outcome, or an unindicated patient or grade for osteoarthritis. These are the red flags you should not. I don't do it in these patients. Thank you very much. So I will take question answer of this session and then we'll come to the next section. Thank you. So we have few questions after this session. I'll take those one by one. By one question by Dr. Rahul, as shown you in the literature, high dose is to be given for good results. How much high dose and how much do you give? So in the literature it is suggested that more than 20 million cells per large joint is optimal for the good health and recovery or pain relief in the patients. We usually give more than 50 million cells per large joints, per knee or per hip joint. So that gives us encouraging results, and we are quite happy with those things. Another question is by Ms. Pathak. Follow-up PRP are derived from which sites of the patient bone marrow? Do we need to again go for anesthetic procedure after 3 weeks? So the follow-up PRP which we give after 3 weeks, it is a PRP which is derived from the blood, peripheral blood, not from the bone marrow. It is not a bone marrow aspirate concentrate. It is the platelet rich plasma which we take it from the peripheral vein and then derive a PRP, make a PRP and then inject it. So patient, it is an outdoor procedure, patient do not need for go for any kind of anesthesia for this PRP. Okay. One more question is, how many cases have you done in India till now? So we have done approximately 900 cases, and you can say 1600 joints 1600 plus joints we have done in last 7 years, and approximately 80-85% patients are benefited by this SVF. One question by Dr. Sanjay Tripathi: what is difference in SVF and PRP, and which is more effective? So I have shown one slide of the tissue engineering. It has three factors. One is the scaffold, another is the cell, and third is the bioactive molecules. So the PRP gives only the bioactive molecules, the cytokines and the growth factors, whereas the SVF gives you the cells, scaffold, as well as the bioactive molecules. So definitely SVF is more potent and more effective than the PRP, and that there are so many differences. Just like the PRP is a acellular, somebody has written this also, that PRP is a acellular and is a growth factors and cytokines, we all know that the SVF is a heterogeneous mixture of cells which has the pericytes and other cells also, which helps in the tissue repair and regeneration. Effect of PRP in osteoarthritis is proven only to improve the pain. No, it has not shown that it is help in cartilage or hyaline like cartilage regeneration. Okay. Any other questions? Or then we'll move to next session of video technique of fat aspiration, and how we separate the cells from the fat and how we inject it. So we'll take one video at a time, and then we'll discuss on those things and we'll proceed gradually. This is a table on which we collect the fat. This is a box we have designed, which has one outlet for negative suction and another inlet for the lipoaspirate, which will come into the box. Okay. Initially, we will fill it approximately 300 ml of normal saline and soda bicarb to neutralize the lipoaspirate. Another thing, in the instrumentation, we need an 11 number knife, local anesthesia, skin marking pen to mark the area where you get the amount of fat. One infiltration cannula through which we infiltrate the lipocyte anesthesia, and one suction cannula, lipoaspiration cannula. So this is the thing which we need for the lipoaspiration. The patient, initially we mark the area where we can have a good amount of fat. Okay. The area, it is approximately 2 centimeter above and medial to the anterior superior iliac spine. From this area, we have easy access to the whole of the abdomen. So after just giving a local anesthesia, we'll infiltrate it, and the patient is under local anesthesia. Patient is not sedated or given any kind of spinal anesthesia. Start. So this infiltration cannula, we have started infiltrating the fluid in the abdomen. I think you can see this bulge. The fluid is gradually accumulating. So another thing, I would like to tell you about the composition of this infiltrating fluid. टीवी आपने वहां लगाई पीछे. This infiltration fluid which we are infiltrating, it consists of 1 liter of normal saline added with 1 ampule of adrenaline, 1 ampule of soda bicarb, and 40 ml of xylocaine 2%. We have prepared and kept ready 2 liters of such fluid for tumescent anesthesia. Can you see? We change the direction of cannula. I think you will be able to appreciate the fluid getting accumulated underneath the skin. We have to be very careful near the umbilicus. As a part of pre-operative profile, we always get ultrasound of abdomen done in all the patients to see for any occult hernia or any kind of abnormality in the anterior abdominal wall. So I have marked the line beyond which I would not like to go, because going too much near to the diaphragm and the costal line, it gets painful to the patient. So near umbilicus, we go in this direction. Give me the pen. So the direction of cannula is always missing the umbilicus. Can you see like this? This is the direction of cannula. Yeah.
Yes, sir.
In this way, we always miss the umbilicus. We don't want to go near to it.
Yes, sir.
And after infiltration of the cannula, infiltration of the fluid, we have to wait for 10 minutes for proper distribution of this fluid into the area and good effect of anesthesia, as well as some loosening of the fat, so that it can come easily with the suction. So from this same thing, we go to the flank also. Show
Yes,
the
sir.
cannula.
Yes, sir.
Okay, so this is a lipo aspiration cannula. It's less than 3 millimeter in diameter. It has 3 holes in the distal part. On these holes, can you see these holes?
Yes, sir.
So these holes have special design. These are blunt on the tip, but the inner aspect of these crest is sharp. So it cuts the fat and brings it up. But on touching it, on superficially palpating it, it doesn't hurt. Okay, it is quite safe if you are conscious, or just like any other surgery. Yes.
How exactly is you using your left hand? I mean, it is to evaluate the fat remaining, or you pressure it to push it inside. Well, what
yeah.
is the exact
So,
application of your left hand?
Left hand is holding, stabilizing the skin. Can you see this? Stabilizing, little pressure, and I'm feeling the cannula throughout. I'm feeling the cannula so that I don't go in. I'm pressing it little down so that that rectus or the abdominal muscle go further down.
Take it out.
Okay. So if you have done the proper marking beforehand, you know where to go, where not to go. We'll discard this initial fluid, and we'll add more soda bicarb to this, and have a clear and more fruitful
Washing.
We are washing the lipoaspirate. We have added more fluid to this. Let it settle down now.
How much fluid, sir?
How much is not a criteria, it's just to wash it, dilute it, and discard the excess of fluid. Chalo, isko on karo.
Okay, so the fat is always going to be in the upper margin.
Yeah, and we are washing the fat. Okay, we need to wash out that fluid which came along with the fat.
So the washing will be over by the time it becomes transparent, the rest of the
No,
fluid?
no, 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 no. We don't want to do that much. बंद करो sir.
Okay. Like the end point.
End point is just to wash it once or twice to remove excess of fluid which was used as a tumescent anesthesia
Yes.
because it contains local anesthetic.
Okay.
So we just want to neutralize the pH of the solution to
Okay.
keep the cells more cells alive.
Okay.
So you have washed it with what?
Normal saline along with the soda bicarb. 1 liter saline, 1 ampule of soda bicarb. We have removed the suction tubes and capped that box, and now just cut it.
Is it
Yeah.
gravity assisted discarding or?
Yes, it is gravity assisted. Show that the disposable bag where it is going. It's a Euro bag connected to this point lock. बंद हो गया साउंड आ रहा है. Yeah. So we have seen the process of aspirating the fat from the belly fat, and it is collected into a jar, and then from this jar we will separate the SVF with the ultrasonic. So we have another video of dressing, how we dress the wounds we have created or the stab wounds, and then another third video for SVF separation from the adipose tissue. Okay, so any questions in this video? Questions? Can you show? Yeah. So what is the advantage of extracellular matrix? So extracellular matrix, as we have discussed in the last presentation itself also, it provides a scaffold for binding of the cells to form the cartilage or hyaline like cartilage. So in the regenerative medicine, 3 components are important. One is the extracellular matrix or the scaffold, second is the cells which regenerate and give rise to specific lineage of cells, and third is the biological active molecules or the cytokines and the growth factors which facilitates the procedure. So that's why it is important. And how it is superior to bone marrow. So SVF which we derive from the adipose tissue is superior to bone marrow in 2 aspects. So one, because of the age, the cells decreases in the bone marrow. So for the older patients which are there for the osteoarthritis, BMAC is not suitable for older patient in osteoarthritis. Although BMAC has given good results for focal chondral lesions in young patients, which we regularly do for the cartilage injuries, but BMAC is never promoted or advised for osteoarthritis. So, but SVF is good for osteoarthritis, one thing. Second, bone marrow does not have this extracellular matrix also, so which we get it from this also here. So there is no need of the number of cells are more because we can harvest more and more of adipose tissue. So the number, we can have more number of cells in the SVF. So that's why it is better in my opinion in comparison to bone marrow. And another question is, can't we take it from thighs? Yes, we can take it from thighs. If there is less fat in the anti-abdominal wall and more in the thighs, we can harvest it from there. but personally I don't take it from the thigh or the buttocks, but I take help from the plastic surgeon or the general surgeon to aspirate fat if there is less fat in the anti-abdominal wall. Another question, can we inject in small joints like thumb and big toe? Yes, we can inject it. We can inject in the patients with osteoarthritis who have also the osteoarthritis of the first CMC joint. Mostly we have seen in older patient, we can see the first CMC joint arthritis is very common, and also in the big toe. But big toe osteoarthritis is less common. It is usually seen in gout or the hyperuricemia cases, but we don't do SVF for the gout. So small joints it can be given, there is no contraindication for it. For few patient, initially we have given this SVF for rheumatoid arthritis, and in those cases we have injected in small joints also, and we have seen very good relief in the pain and improvement of the some deformities also. But in rheumatoid arthritis now we don't do it because the results are not long lasting, because the disease process, the results usually are not more than 1 year. So we stop doing SVF in rheumatoid arthritis. Our strict indication is osteoarthritis and AV hip. One question, my doctor, is it covered under Mediclaim? Yes, it is covered under Mediclaim, and we get it very easily cleared here in Indore itself, and maybe other places initial problems are there because it is difficult to convince Mediclaim guys that this process is now based on evidence and it has got clearance from the government authorities. So it is covered in the Mediclaim. Any other questions? So if you have any other questions, you can put it into the chat box, and we can start and take another video of cell separation, cell dressing, wound dressing of video. So here what we
over
do,
here we are going to place Gamgee that will help us to absorb any soakants and all, because we had aspirated around 1.5 liter of tumescent anesthesia. So that will be secreted out from that wound, and we have to add in soak sheet, and utilizing an abdomen,
Okay.
we have to bind it off.
Okay.
The process they will be showing it to you.
So we haven't percutaneously closed the wound.
No, we will not. That wound is of 3 mm size, so that will automatically get healed off. In the span of 15-20 days or a month, patient will even not being able to realize from which area adipose tissue is aspirated out. So there will be no wounds, no cuts, no stitches, nothing can be observed of, and stitches are not required in it.
No suction drain.
Yeah, no stitches are.
We'll just let the fluid out and let it soak.
Yeah, that will get soaked off.
How often do we change the dressings in our regular setting?
On second day we are going to open it off and we'll change those soak pads, and we'll suggest patient to tie it up for next 3 days.
Okay.
For just for cosmetic reasons, that skin will not lose off from that area and nothing else. So this is the dressing done. All dressing part is being done.
so the wounds are not stitched because if there is some excess amount of the fluid or the adipose tissue that can be drained from those puncture wounds. So that's why we don't stitch it, and there is no need of stitching it because it heals nicely without any delay in the healing. Okay. Any questions? Do you need another SVF fraction injection after 5 years? So it's a nice question. Patient usually do ask for repeated injection after 5 years. We have done in 1 or 2 patients, but usually it is not done. It is not a routine practice of repeating SVF in every 5 years. What is the approximate cost for the patient? So the cost of the patient, cost to the patient depends on two factors: how many joints are involved, and another thing, how much tubes we are going to take for the patients. So routinely, if you see for both the knee joints, and if we do 6 tubes processing for SVF, approximately 3.25 lakh rupees expenses occurs overall for the patient, which includes the SVF procedure itself, hospital stay, and routine medications. Is the procedure approved under CGHS? So at present it is not included in CGHS guidelines, and we don't have CGHS code for this procedure. Any other questions? So we'll take another video which is very interesting, and because liposuction or lipoaspiration is not a big deal for any surgeon. Everybody has seen it, how it is done, and the procedure itself is not difficult to do it. But the thing is how we get SVF out of this adipose tissue. We'll see in this video. So the harvested fat which we have taken in the patient is now transferred to the biosafety cabinets. You see this is a whole biosafety cabinet which is covered, and it has a positive positive air pressure, so that the air from outside, which is filtered through HEPA filters, will come out. Outside air will not go into that chamber. Okay, so this fat is then transferred into the tubes. And this is a whole automatic pipette by which we are sucking the fat from the jar and transferring it into the tubes. You can see this. These fat clumps usually are formed because it is very sticky sort of thing. Yeah. So in each and every tubes we will distribute this fat equally as per the need of the patient, and each tube can have approximately 40 to 45 ml of adipose tissue. So even if you see that into the jar, that yellow part which is the adipose tissue and the reddish part which is the fluid, we have washed it with the normal saline and soda bicarb to neutralize the pH, but also you have seen that still there is a fluid into the jar, and which we have taken it out from and then separated into the tubes. So now first of all we will spin off. Centrifugation will be done to remove the fluid from the adipose tissue. Okay. Once it is done, then from each tubes, after centrifugation, you will see that there is clear fat in top of the tubes and there is a fluid in the bottom of the tubes. So this bottom fluid which was having the normal saline and the some amount of local anesthesia is now removed, and these tubes are now kept into the our automatic system of ultrasonic cavitation. It has you can see that a stainless steel probe which is going into the fat that emits the ultrasonic waves. So this ultrasonic energy break down the fat. You can see there is difference in the color of the adipose tissue. So those tubes which are not sonicated are little reddish yellow or orangish, whereas that ultrasonic cavitation is being done, that is slightly more lighter yellow in the color. Then after this, centrifugation was done, and once the centrifugation is done, we are removing the adipose tissue from the top of the cells, top of the tubes. And it is, when it is collected, we do the filtration of the fraction. This is a fresh. This is a final process of filtration of the SVF. After filtration, we do the, this is the machine, the Muse machine, which do the cell count and viability check. So you can see those cells. Yeah. So just last image, मशीन का डिस्प्ले इसके, हाँ पॉज करना इसको, बस स्टॉप. So here you can see that 4.7 into 10 to the power 7 cells per ml and 80% viability, and you can see that total 5.9 into 10 to the power 7 cells per ml, and out of which 80% are viable, and 4.7 into 10 to the power 7 cells per ml are there. So total viable cells in whole SVF is 6.1 into 10 to the power 8, means it is 610 million cells are there from around 400 ml of fat we got it. Then these cells are then injected into the joints. So we will have a video of injection. It is very simple. We can show the video, next video. So this is just for demonstration purpose, that this is the patella and the superolateral portal, which we usually take it for arthroscopy and for injection also. From this superolateral part we inject into the joint, into the suprapatellar fossa, and you clearly, we don't have any resistance, it goes very easily into the joint in that case. This is a very simple process. It's very simple process of injecting into the joint, into the knee joint. It's little tricky in putting it into the hip for as an intra osseous injection. ठीक है, दूसरा second knee. Okay. 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 So do we have any questions in this session? Hmm? This procedure have the necessary government clearance. Yes, we have necessary government clearance to perform this adipose derived stromal vascular fraction for the treatment of knee pain. And do you have any experience? So I don't have any experience with lipogem, and so I cannot comment directly on with my experience, but the results of the lipogem were initially good, but not the long term results. The result literature has shown that with the lipogem there is a lot of fibrosis into the joint. For those who who are not aware of the lipogem is basically a micro fragmented fat or nano fat. That fat is directly injected into the joint. It was not the cells, it was just a adipose tissue which is microfragmented and injected into the joint. How soon the patient starts seeing the effect of SVF? Okay. Patient usually are improved within 3 to 6 weeks, and some patients, approximately 50% of patients, have improvement in 6 to 12 weeks. So it can take 1 to 6 month time for patients to get improved for long term. Although pain relief is seen in initial few days also, we ask our patients to take little rest and do not do exertion once they get improved, because if the pain is relieved, the lifestyle which was there for years, which was slower, you cannot make it fast overnight. So if they start doing exertion, they started having pain in the their tendons and the joint capsule is stretched. So we advise them to go gradually and increase their activity level, and meanwhile they also do exercises for improvement of their muscle strength and range of motion. Will the cost of be lesser in first CMC and big toe and other feet joints, and no SVF tubes less, and number of, yes, so if number of tubes are less, the cost will definitely be less, but regarding this cost, you can put your number onto that, and this Xpert clinic will approach you and will discuss the cost in details. Why only, okay, why only the laterals? So we can inject it from any other portal also, but we have to be very sure that it is injected joint into the joint freely, not into the tissue. So we can definitely inject it from the arthroscopic portals, anterolateral portal or anteromedial portal. There is no harm in doing that. The cost of full setup and equipments, exact cost I don't know, but we can connect you with our marketing team and sales team. They will discuss this setup and equipment cost with you, Dr. Tripathi. So another video we will play with the intraosseous injection in avian hip. Now I am anteriorly. I'll just go now, na, into the bone.
Yes.
ये हाथ का मूवमेंट दिखाओ बेटा, हाथ का मूवमेंट दिखाओ, रिलैक्स रहना.
Vinay sir, can you explain how much are you pressurizing it?
Just going by the movements. Can shoot it again.
But the depth of the
रुक जा,
needle,
मत कॉपी करना अभी, रुक जा. हाँ, sorry.
the depth which it has gone intraosseous, that can come on a lateral view.
Yes.
Lateral oblique.
Yes. But
I think it is around half centimeter or.
yes, you can see that the needle is progressed in two images of CM. Can you see the both images?
After this hitting the bone, it has entered at least 1 centimeter inside.
Yes.
Then almost into the anterior.
Yeah, superior.
area,
Yeah,
good
should
area.
see. Yeah, okay. Can you see both the
Yes.
images?
Yes, sir. Yes.
Okay. Now at this time, I'll inject this.
If you put a dye with it, then we can see.
Yes,
what
will
the
definitely we can see, but actually,
dye is.
I don't know dye how much. Relax.
It will be
We don't know if it's
destructive to the
cytotoxic
cell.
or not.
So can you show this? जो injection जा रहा है बेटा?
We can see the syringe being. It will be a hard push, no, because
It is a bit harder push.
hard push, yes.
Yes, sir. Clear, visible.
Sometimes relax रहो.
Yes, intraosseous is causing some pain. Yes.
Patient seems relaxed.
So if it is not going easily, then you can
Yes.
again change a little bit the position.
So intraosseous is a new concept.
Now it is going.
Yes, now it has made a space in the marrow.
Yeah,
Now there will be pain.
yeah.
Patient will
So now it is approximately 1.5 ml left, which I'll withdraw gradually. Once I lose the resistance, it is now going easily.
Yes.
Can you see this?
Yeah, this is yes,
This is intra-articular.
Intra-articular.
Yeah,
That is good. Perfect.
yeah. Okay. मैं उधर जाना है मुझे.
So can you just talk to the patient and ask कितना दर्द हुआ उसको? How
कितना
much
दर्द हुआ आपको? एक बार बोल दो.
बोल के बता.
माइक तो मेरे पास है. कितना दर्द हो?
It was
Can you hear?
no, it's not audible.
थोड़ा जोर से बोलो भाई.
अब थोड़ा सा दर्द हुआ थोड़ा सा
बस ठीक है.
स्टार्टिंग
ठीक है. Okay. So it was full pain-free injection. Intraosseous part was also pain-free.
या इस तरह का दिखाओ बेटा. एक मिनट रुक जाओ.
हेलो
Are we intraosseous or intraarticular, sir, right now?
हाँ, we are preparing other knee, other hip. Intraosseous, intraarticular both are done, na?
Sir, how many mLs in intraarticular and
I have given approximately 3.5 ml intraosseous and 1.5 ml intraarticular.
Okay.
दिखाओ बेटा एक बार शूट करो. इधर पे लाओ थोड़ा सा. This head is a little bit more damaged in comparison to the other side. Can you see this?
Yes, sir. It's clearly distinguishable.
So shoot once more. Okay. Relax, relax. दिखाओ बेटा. रिलैक्स रहिए. रिलैक्स. आराम से दिखाओ बेटा. रिलैक्स रिलैक्स रिलैक्स. Icon. So similarly we inject it into the another joint. So if you have any questions, so we will take it. And do you have any? Or we will move to our next. What needle is used for femoral head? So it was 18 gauge spinal needle which was used to put intraosseous injection into the hip joint. And simply it is injected with inserted into the head with the hand pressure only. Okay. So we have another presentation on post-operative protocol and a few dietary things important in pertinent to which are pertinent for the SVF procedure. So we'll take another lecture by Dr. Monica. And
Very good afternoon, everyone. The SVF cellular grafting therapy has already well explained by the Dr. Vanessa. Now I'll explain about the post-therapy follow-up and care. As we all know that post-op care and follow-up is the most important part of the patient's recovery. So let's start with the post-lipo aspiration instruction. The abdominal dressing part has already explained by Dr. Vanessa. Now I'll explain about the lipoaspiration instruction. The surgeon need to guide the patient to keep the abdominal binder for 3 to 4 days from the date of the lipoaspiration. The patient should avoid hot water bath for next 2-3 days because there may be a possibility of profuse bleeding due to vasodilation. Any wound discharge, if the patient feels after 4 days of lipoaspiration, he should contact to either medical coordinator or treating surgeon to avoid any kind of a problem. Our past experience says that some of the patients usually come with the common problems such as in anterior knee pain or thigh pain, which is generally due to tendinitis. So we don't need to worry about this problem. We can recommend to the patient the cold fermentation, and this is the right time to enhance the muscle strengthening exercises. Another common problem is abdominal itching at the site of lipoaspiration. So even in this problem, we don't need to worry. So we can recommend the patient the simple coconut oil or lactocalamine lotion at the site of itching at least for 15 days regularly. Now we'll talk about recovery time. Like other orthopedic surgeries, the recovery time varies from patient to patient. But as per our experience, patient getting relief from very first day after this procedure. But the complete relief from the pain, it will take 3 to 4 months. Now I'll explain about the standard follow-up protocol. The first one is activator schedule. The first activator supposed to be done 7 days prior of this cellular grafting procedure. The second activator has to be done between 42 to 48 days after the cellular grafting procedure. Now the follow-up protocol. To track the patient's progress, we used to take globally accepted WHO score of knee pain and WHO score of avian patients. The same record will be uploaded on the portal so the surgeon can also assess the progress of the patient. On the first year, we used to take the score in every 3 months, like after the 3 months, 6 months, 9 months, 12 months. And onwards, we used to take this score continuously every year. As you can see, we have developed the huge library of exercise videos. You can recommend to your patient, you can share with your patient directly from the YouTube channel. You can also get all these exercises to our portal also, so the patient can understand how to do the exercises in a right way. Thank you.
इसका लेक्चर खत्म हो गया. कोई क्वेश्चन है? So thank you everybody. Now we are open for question answers. So one question, how do you culture cells? So we don't culture cells here, Dr. Rahul. We are doing this procedure in the same sitting, in same surgical setting. We are harvesting or aspirating the fat and separating the cells from that fatty tissue. And these cells are not the adipocytes. These cells are the adipose. These are mixture of cells which altogether make a SVF. These are the pericytes basically, and it is injected into the joint in the same sitting. Whole process takes approximately 2 hours, and that's it. So there is no culture of cells here. do there any chance of fat embolism? So the chances of fat embolism are very minimal. We have not seen in any case. Literature has not reported any case because it is very small cannula and the limited amount of fat is aspirated, and that too by the Gentry maneuver. So this type of complication we have never seen in our practice and in the literature. But fat embolism has been reported in liposuction, usually the mega liposuction, which has been performed for the cosmetic purpose. Any other questions? So I'll thank you all for your presence here. You took all the time on Saturday afternoon for the SVF therapy and for the regenerative medicine. I'll thank Dr. B.S. Rajput sir also. He has done a lot of work in regenerative therapy. He was also here and listening to the program, and all the colleagues and friends and seniors, we will be more than happy to answer your questions in the future also. You can send your question to this link. You can do we have any WhatsApp or contact number we can display through which I'll share the WhatsApp number for further inquiries if you have any, and email ID for questions जो भी रहे. Any kind of scientific help, if I can help you, literature, regarding evidences, regarding the technical point, medical guidance, or any scientific data if you want from our side, you can ask directly. इसको display कर दो बेटा. So that number and the email ID is shown into the chat box. You can note it down if you have any kind of queries or further communication if you wish to establish with us. Thank you all for being with us this Saturday afternoon, and we'll try to make it a regular program. There was a good attendance, approximately 100 people joined it, and still by the end of the program more than 70 people are there with us. So thank you very much. This is an encouraging and unique kind of experience which we also have. So we'll try to improve. You can suggest also how do we can improve the process, and how do we can improve the communication system, so that in future we can have more and more such seminars and workshops, and everybody in the society can be benefited. Thank you very much.